Good afternoon, students. This week we're going to continue on with our GI information while focusing more on GI disorders. So the learning objectives will include looking at the pathophysiology, manifestations, and nursing framework for each one of the gastrointestinal disorders we'll discuss. More specifically, looking at priority assessments and interventions for these disorders, and more specifically doing a case study and looking at some more specific complications of these disorders. So let's jump right in. We're going to start with gastric and duodenal disorders. So gastritis is the inflammation of the stomach lining caused by the breakdown of its protective mucosal barrier, exposing tissue to digestive acids. Acute gastritis develops suddenly and often resolves on its own. And the common causes include dietary issues, medications, alcohol, bile reflux, or radiation, as well as severe cases may occur from ingesting strong acids or alkalis. In chronic gastritis, that involves long-term inflammation and tissue damage, often due to H. pylori infection or stomach ulcers. It can also be linked to autoimmune diseases, poor diet, certain drugs, alcohol, smoking, and chronic bile or pancreatic reflux. So, with acute gastritis, the symptoms include epigastric pain, indigestion, loss of appetite, hiccups, nausea or vomiting. Erosive forms may cause gastrointestinal bleeding, and you may see things like melena, which is the tarry stool, hematoemesis, which is throwing up blood, or hematochezia, which is the streaks of blood in the stool. Chronic gastritis, the patient may present with fatigue, heartburn, which is pyrosis, belching, sour taste, bad breath, early fullness, anorexia, nausea, and vomiting. It can also lead to pernicious anemia from vitamin B12 malabsorption, though some patients may be asymptomatic. And diagnosis is usually confirmed by endoscopy and biopsy for histology examination. So, acute gastritis, the management includes avoiding alcohol in foods until symptoms resolve, with supportive care such as IV fluids, nasogastric intubation if needed, and medications like antacids, H2 blockers, or proton pump inhibitors. With chronic gastritis, the treatment focuses on lifestyle changes, including diet modification, stress reduction, rest, and avoiding alcohol and NSAIDs, along with appropriate pharmacological therapy. Reducing anxiety through a calm, reassuring approach and clear explanations. Promoting nutrition includes withholding food and fluids during acute episodes, then gradually reintroducing clear liquids and solids, avoiding caffeine, alcohol, and smoking, and providing counseling as needed. Maintaining fluid balance by monitoring intake and output and watching for dehydration, electrolyte imbalance, or bleeding, and relieving pain through prescribed diet modifications and also medications. So now we're going to move on to peptic ulcer disease, PUD. This is the formation of an ulcer or excavation in the stomach, pylorus, duodenum, or esophagus due to mucosal erosion, often linked to H. pylori infection. The risk factors include excessive acid secretion, certain diets, chronic NSAID use, alcohol, smoking, and family history. Symptoms usually include the dull, gnawing, or burning mid-epigastric pain with possible heartburn and vomiting. Diagnosis is confirmed through an EGD, and treatment involves medications, lifestyle modifications, and sometimes surgery. So, comprehensive assessment combining detailed history, especially diet symptom relationships, medication review with focus on GI irritants, especially NSAIDs, and physical examination to detect complications. The emphasis should be on abdominal assessment and a 72-hour diet diary that will suggest the pattern recognition, and that is crucial for diagnosis and management. So the goals for the patient with the gastritis are usually to relieve pain, reduce anxiety, maintain nutritional requirements, and also to make sure you monitor or there's an absence of complications. The holistic approach addressing physical comfort, pain, and nutrition, also psychological well being, reducing anxiety, and reduction through non pharmacological measures, complication prevention, and patient empowerment through education. The emphasis should be on regular meal timing and NSAID avoidance, and that reflects the key principles in managing the GI. You want to definitely make sure you avoid smoking, NSAIDs, spicy food, alcohol, and coffee. So, some complications involve either bleeding, this requires rapid intervention to prevent shock, structural breakdown that could come through perforation or penetration requiring surgery. Metabolic consequences are fluid and electrolyte imbalances or malnutrition. And post surgical problems include dumping syndrome, leaks, infections. And often, especially if you have peritonitis or any type of internal hemorrhage, these are medical emergencies, and the provider must be contacted immediately if signs, especially of shock, are present. So, the key difference between chronic gastric and duodenal ulcers are timing of pain relative to meals. With a gastric ulcer, the pain is when the person is eating or shortly thereafter. And with a duodenal ulcer, the pain is between meals and it's actually relieved by eating. So a memory trick for you is duodenal ulcers equal hungry ulcer, pain with when the stomach is empty and it's relieved by food. Both are strongly associated with H. pylori infection and NSAID use, and both can cause the same complications, including hemorrhage, perforation, and penetration. So gastric cancer is more common in older adults. Average age is 68 and occurs more frequently in males, Hispanic Americans, African Americans, and Asian Pacific Islanders than in Caucasian Americans. It has a poor prognosis, with 95% being adenocarcinomas that often spread early to lymph nodes. Right? The risk factors include certain diets, chronic gastric inflammation, H. pylori infection, pernicious anemia, smoking, low stomach acid, gastric ulcers, previous partial gastrectomy, and genetic predispositions. Okay. So, the manifestations usually are vague symptoms overlap with more benign conditions like gastritis or peptic ulcer, leading to delayed diagnosis when the cancer is already advanced and harder to treat. This is why gastric cancer has a poor prognosis despite treatment options. And treatment usually is with chemotherapy, targeted therapy, radiation, surgical removal of the tumor if possible, and palliative care. So let's see. The incidence of this actually happens in adults, males, Hispanic, African Americans. We already talked about that. Okay. Um, and small bowel tumors have a high malignancy rate and can be silent or present with non-specific GI symptoms. They show similar demographic patterns to gastric cancer, especially in older adults, males, African Americans at higher risk. The occult bleeding and potential for obstruction make early detection more challenging. This is usually treated with surgery and chemotherapy. So, assessment combines physical findings, especially abdominal exam for masses, tenderness, distension. Nutritional status often is compromised due to these symptoms. The modifiable risk factors include smoking and alcohol, and psychosocial factors to address the whole person and prepare for treatment planning should be included. The multidimensional approach recognizes that cancer affects physical, emotional, and social well being. So, the planning and goals for the patient with this cancer are to reduce anxiety, maintain optimal nutrition, relieve pain, and support adjustment to the diagnosis. Comprehensive monitoring for both disease progression and treatment complications, symptom management through medications, and thorough patient education to promote self care and early complication recognition are needed. Special attention to post gastrectomy complications like dumping syndrome, as well as steatorrhea, which is like the fatty oil based stools, reflects the significant impact of surgical treatment on the digestive function. So we talked a little bit about dumping syndrome, but just let me go over it again. It's also known as rapid gastric emptying and is the most common complication after partial gastrectomy. Alterations in the gastric anatomy after surgery or interference is into the extrinsic innervation following a vagectomy may alter gastric emptying. After pyloric resection or bypass, concentrated chyme, partially digested food may enter the small bowel rapidly, causing abdominal distension, inappropriate gut hormone release, and rapid glucose absorption. Early clinical manifestations, this happens within 15 to 30 minutes after a meal, include dizziness, tachycardia, pallor, sweating, diarrhea, and palpitations. This is usually when you want to catch the person having dumping syndrome. Some of the signs of late dumping syndrome are they occur 1 to 3 hours after meal, and they include symptoms of hypoglycemia, weakness, sweating, dizziness, and both can be life threatening. Dumping syndrome is managed primarily by planning dietary intake to allow smaller boluses of undigested food to enter the intestine. Meals are small and more frequent. Liquids and solids are taken at separate times. And also, you want to make sure that other complications of gastrectomy include wound infections, leaking, anesthetic sites, strictures, and internal bleeding. So now we're going to talk a little bit about medications. So antacids work by neutralizing excess stomach acid and increase lower esophageal sphincter pressure. Common types include aluminum hydroxide, magnesium hydroxide, calcium carbonate, and sodium bicarbonate. Nursing actions will include checking for contraindications. So there's an interaction with synthroid, assessing kidney function, especially for those taking magnesium hydroxide. Client education should include taking antacids 1 to 3 hours after meals and at bedtime when acid secretion is highest, separate from other medications by at least 1 hour to avoid absorption issues. Proton pump inhibitors block acid production by inhibiting the gastric parietal cell pump responsible for secreting stomach acid. Common examples include um, Prilosec and Protonix. Those are some of the most common, and also Prevacid. So, nursing's actions include monitoring for electrolyte imbalances, watching for hypoglycemia, especially in clients with diabetes, assessing for abdominal cramping, fever, and diarrhea, which may indicate a sign of C. diff. And client education should be, especially with those taking PPIs for a long term, this can increase fractures, particularly in older adults. So H2 blockers reduce stomach acid production, similar to antacids, but with a longer duration of action. Common examples include Tegamet, Pepcid, Acid AR, and Zantac. Nursing actions include cautiously using this in clients with kidney disease, and client education is you want to make sure they take this medication with meals or at bedtime and separate from antacids by at least 1 hour before or after to prevent interaction. Prokinetic agents like Reglan enhance gastric emptying to improve digestion and reduce reflux. Reglan's often sometimes given for as an antiemetic as well. Nursing actions include monitoring for extrapyramidal side effects, including akathisia, which is restlessness, dystonia, which is involuntary muscle contractions, tardive dyskinesia, which is involuntary facial movements. You'll see some of that with some of the SSRIs as well. Client education includes avoiding long-term use due to the risk of neurological or psychotropic side effects, and reporting any abnormal or involuntary movements immediately. So, although they are not entirely recommended unless a life threatening consequence ensues, there are a wide variety of treatment regimens available for eradicating infections in individuals with clinical manifestations of disease attributable to the H. pylori. The success of H. pylori cure depends on the type and the duration of therapy, patient compliance, and factors such as antibiotic resistance. There are various treatment regimens for H. pylori eradication, and most include the combination of a PPI and two antibiotics for 7 to 14 days. Using combinations of antimicrobial agents reduces the risk of antibiotic resistance to H. pylori strains. Triple therapies are recommended at first time treatments. Quadruple therapies are recommended as second line treatments when triple therapies fail. So now we're going to look in intestinal and rectal disorders. So constipation is complex and multifactorial, resulting from disruptions in coordinated neuromuscular and secretory functions rather than a single cause. Normal bowel movements require precise coordination of reflexes, muscle relaxation, and pressure changes. Manifestations include fewer than 3 bowel movements per week, abdominal distension, pain and bloating, a sensation of incomplete evacuation, straining at stool, and elimination of small volume or hard, dry stools. Ooh, hold on. You want to start with a comprehensive history and physical, then progress to increasingly sophisticated imaging and functional studies for refractory cases. Those are cases that won't actually resolve with normal medications. The goal is to identify the specific type of constipation, whether it's functional, slow transit, or defectory disorder, to guide targeted treatments, since most chronic constipation has no clear cause and requires systematic evaluation. So, cardiovascular complications include decreased cardiac output from straining. Anorectal complications include fecal impaction, which is hardened stool lodged in the rectum, hemorrhoids, which are swollen rectal veins from straining, anal fissures, which are tears in the anal lining, rectal prolapse, which is a rectum that protrudes through the anus. Some colonic complications include a megacolon, which is an abnormal dilation of the colon, and the key patterns are complications result from either mechanical trauma, which is the straining and hard stool that can be hemorrhoids, fissures, and prolapse, obstruction from impacted stool, systemic effects from prolonged straining, which is the decreased cardiac output, and the chronic distension from prolonged stool retention, that's the megacolon. Oh, my bad. Let's do that. There are four classes of constipation based upon their underlying pathophysiology mechanisms. Each class has different underlying mechanisms, from simple dietary fluid issues, which is functional, to complex neuromuscular coordination problems, which is defectory disorders, to medication side effects, which are opioid induced. Constipation management is primarily lifestyle based. You want to educate the patients that normal varies by individual and that establishing a routine with proper diet, hydration, physical activity, and timely bathroom visits is more effective and safer than relying on laxatives long term. Empowering patients with knowledge helps them take control of their bowel health. The overall approach is non pharmacological, lifestyle based interventions focusing on diet, exercise, proper mechanics, and routine establishment. Medications should be used cautiously and not as a long term solution. Diarrhea is characterized by both frequency and consistency changes in stool. It's often accompanied by uncomfortable urgency and potential incontinence. It has multiple potential causes ranging from temporary infections to chronic disease processes. Diarrhea involves both intestinal symptoms, cramping, gurgling, distension, and dehydration related symptoms, thirst, along with uncomfortable rectal sensations. The combination of frequent liquid stools with tenesmus can be particularly distressing for patients. So, some common diagnostics include a complete blood count, serum chemistries, urinalysis, stool examination, and endoscopy or barium enema. You want to maintain contact precautions if there's suspected C. diff infection. Diarrhea can progress from a GI problem to a systemic issue affecting hydration, status, electrolyte imbalance, cardiac function, and skin integrity. The severity escalates from fluid loss to potentially life threatening cardiac complications, while chronic cases cause additional skin care challenges. Conservative management, focusing on gut rest through dietary restrictions, adequate hydration, skin protection, and symptom relief is ideal. The goal is to reduce intestinal irritation while preventing dehydration and skin breakdown. Dietary restrictions are most aggressive than constipation management, which encourages fiber and fluid intake, reflecting the need to calm an overactive bowel. Fecal incontinence is a multifactorial disorder requiring intact sensory, muscular, and motor function. It's surprisingly common, especially in long term care settings, and significantly affects patients' dignity and quality of life beyond just the physical symptoms. So, some manifestations include minor soiling, occasional urgency, loss of control, and complete incontinence. Manometry is a procedure that measures the pressure and movement of muscles in the esophagus or rectum to evaluate a variety of conditions. Also, history and assessment should include a history of the present etiology, rectal examination, endoscopic examinations, radiographic studies, a barium enema, CT. So, management of fecal incontinence involves a stepwise approach. First, you want to correct the underlying condition contributing to the incontinence. Conservative measures include fiber supplements, pelvic floor muscle training, digital rectal stimulation for refractory cases. Advanced interventions include sacral nerve stimulation via implanted subcutaneous device, and surgical options include an anal sphincter reconstruction or repair, artificial sphincter implantation, sphincter bulking or synthetic injections, and fecal diversion procedures. So, nursing interventions for education for fecal incontinence include bowel management, initiating a structured bowel training program, using briefs sparingly and providing assistance with toileting as needed, administering skin cleansers and protective barriers to prevent skin breakdown and maintain integrity, employing when necessary to manage severe incontinence is fecal management systems, and providing psychosocial support to reduce embarrassment and anxiety. Irritable bowel syndrome, IBS, is a chronic functional disorder marked by recurrent abdominal pain and altered bowel habits, including diarrhea, constipation, or both. The occurrence is it usually affects 15% of US adults, more commonly women than men. And some common triggers are stress, sleep deprivation, surgery, infections, diverticulitis, and certain foods. So, some common manifestations include alteration in bowel patterns, either constipation or diarrhea, pain, bloating, and abdominal distension. Symptom relief, you want to focus on alleviating abdominal pain and managing diarrhea or constipation. Some lifestyle modifications include stress reduction, adequate sleep, and regular exercise. And dietary interventions include increasing soluble fiber, restricting and gradually reintroducing potential irritant foods such as those with low FODMAP diet. So we'll talk about the FODMAP. So FODMAP stands for fermentable, and I'm not even going to try to say that, but that includes wheat, rye, asparagus, legumes, garlic, and onions. Then you have the disaccharides, which are the lactose containing foods such as milk and yogurt, and then the monosaccharides and fructose containing foods such as honey, agave, nectar, figs, mangoes, and polyps, blackberries, lychee, and low calorie sweeteners. So you want to reduce those or you want to decrease those in your diet considerably. So you want to definitely promote self-care, encourage the patient to have regular self-monitoring and healthy routines. Um, teach bowel tracking through bowel habit diary. Have diet management by identifying and avoiding food triggers, keeping a symptom and trigger diary, eating at regular times and separating fluids from meals, and discouraging alcohol and smoking. Teaching relaxation techniques such as yoga, deep breathing, exercise, and mindfulness practices. Malabsorption disorders occur when the digestive system fails to absorb essential vitamins, minerals, and nutrients. The mucosal transport defects cause generalized malabsorption. Some examples are celiac disease, Crohn's disease, and radiation enteritis. Luminal defects are when there's an impairment in the nutrient breakdown or absorption due to bile acid deficiency. So that is Zollinger-Ellison syndrome, pancreatic insufficiency, small bowel bacterial overgrowth, and chronic pancreatitis. And then you have lymphatic obstruction, and that's when there's a disruption in fat transport into circulation. And these are caused by neoplasms, which are cancers or surgical traumas. So laboratory and functional tests include fat analysis, and that evaluates fat malabsorption, lactose tolerance tests, which detects lactose intolerance, the xylose absorption test, which assesses carbohydrate absorption, Schilling's test, which measures vitamin B12 absorption and intrinsic factor production, hydrogen breath test, which detects bacterial overgrowth or sugar intolerances, including lactose, fructose, and sucrose. Imaging and procedural studies include endoscopy with biopsy, which examines mucosal damage. Ultrasound, CT, and radiography assesses structural abnormalities. And other tests include the complete blood count, which checks for anemia, and pancreatic function test, which evaluate exocrine pancreatic insufficiency. Vitamin replacement ensures supplementation of deficient vitamins and minerals. Dietary therapies follow a tailored diet. This is when you meet with a dietitian to improve nutrient absorption. Probiotics may help restore healthy gut flora. Monitoring fluids and electrolytes in order to prevent dehydration and imbalances. And bone health, being aware of increased risk of osteoporosis and taking preventive measures and monitoring for that. Celiac disease is an autoimmune malabsorption disorder triggered by ingestion of gluten, a protein found in wheat, barley, rye, malt, dextrin, and brewer's yeast. The prevalence, it affects about 1% of the US population, and it's more common in women. The associated conditions are possibly type 1 diabetes, Down syndrome, and Turner syndrome. The trend is the incidence has increased over the past decade. It might have something to do with our diet. So manifestations include gastrointestinal symptoms like diarrhea, steatorrhea, which is the oily, foul-smelling, floating stools, abdominal pain, abdominal distension, and excessive flatulence, which is passing gas a lot. Some systemic symptoms include weight loss due to malabsorption. So management of celiac usually is a chronic and lifelong condition, and there's no cure or medication to treat this. So it's mainly management through dietary restrictions. Strict gluten-free diet is essential, and professional guidance through a dietitian for safe and balanced dietary planning. So there's the avoiding brow, which is barley, rye, oats, and wheat. And some of the complications are malnutrition, malabsorption, anemia, osteopenia, and osteoporosis. So, peritonitis is inflammation of the peritoneum. We've talked about this before during the time when we talked about peritoneal dialysis. This is a serious membrane um, issue and should be addressed right away. The most common bacterial implicated is the E. coli, and so the peritonitis can also result from external sources such as abdominal surgery or trauma, gunshot wound or stab wound, or an inflammation that extends from an organ outside the peritoneal area, such as the kidney, or from continuous ambulatory peritoneal dialysis, which we talked about. So, secondary peritonitis is caused by leakage of contents from the abdominal organs into the abdominal cavity. This is usually a result of inflammation, infection, ischemia, trauma, and tumor perforation. Bacterial proliferation also occurs. Edema of the tissue results, and exudation of fluid develops in short time. Fluid in the peritoneal cavity becomes turbid, in increasing amounts of protein, white blood cells, cellular debris, and blood. The immediate response of the intestinal tract is hypermotility, soon followed by paralytic ileus with an accumulation of air and fluid in the bowels. So, some manifestations include a tender, rigid, and distended abdomen, diminished peristalsis leading to nausea and vomiting, and systemic symptoms include hypotension, oliguria, and anuria. And the progression, if untreated, may develop into signs of sepsis or septic shock. And you want to make sure you monitor vital signs closely for signs of these complications. Of course, that would include possibly tachycardia, increased respiratory rate. So, infection control, identifying and eliminating the source of infection, fluid and electrolyte replacement, administering isotonic fluids such as LR or normal saline, colloids, including albumin and electrolytes. Symptom management comes through providing analgesics for pain management and antiemetics for nausea and vomiting. Supportive care could be supplemental oxygen therapy, medications, including broad spectrum antibiotic therapy, and surgical intervention, including emergency surgery if needed. Appendicitis is the most common cause of acute abdominal pain in the US and the leading reason for emergency abdominal surgery. It occurs when the appendix becomes inflamed and swollen due to obstruction by a facus or lymphoid hyperplasia. This obstruction increases intraluminal pressure, leading to edema, ischemia, bacterial overgrowth, and if untreated, gangrene or perforation. And the perforation is what really can kill you. So pain progression begins as vague, poorly localized periluminal pain with anorexia, then shifts to sharp, well localized right lower quadrant pain with nausea in about 50% of patients. Low grade fever may be present. In terms of assessing tenderness, Big Bernie's point tenderness. Rebound tenderness is pain intensifies when pressure is released, and Rovling's sign, which is palpation or left lower quadrant, causes right lower quadrant pain. If rupture occurs, the pain resembles peritonitis, or an abdominal distension develops due to paralytic ileus, and overall condition worsens. So we want to catch this early. So these are those. Thought I had those two signs, but McBurney's point is when you apply and release pressure to this area, the individual experiences increased pain when pressure is released. And this is usually called rebound tenderness. We'll talk a little bit more about that in class. And Rovsing sign is palpitation to the lower left quadrant of the abdomen, which elicits pain in the right lower quadrant. So pre and post-operative care, you want to prepare and support the patient before and after surgery. Infection prevention, monitoring, preventing surgical site infections, monitoring for complications, watching for signs of rupture, peritonitis, or sepsis. Symptom management comes through providing pain control and preventing fluid volume deficit. You want to prevent atelectasis through breathing exercises and also use of the incentive spirometer, providing emotional support by helping the patient reduce their anxiety and providing reassurance. And nutritional support comes through providing optimal nutritional intake during recovery. Did I miss one? Yes, I did. So the diverticulum is a sac-like herniation of the bowel lining through a muscle layer defect, most commonly in the sigmoid colon. Diverticulitis is the presence of multiple diverticula without inflammation. Diverticulitis is the infection and inflammation of the diverticula. Risk factors include increase with age and is linked to a low fiber diet. Diagnosis is usually typically done through a colonoscopy. Management comes through medications such as antibiotics, including also encouraging hydration with fluid intake of at least 2 liters per day, providing a soft, high fiber diet, cooked vegetables, exercise, recommending individual exercise program, and bowel regulation using bulk forming laxatives, um, psyllium, and stool softeners as needed. So, an intestinal obstruction is occurs when there's a blockage which prevents normal flow of intestinal contents. Some types are mechanical obstruction, which is caused by the intralumina or mural obstruction, pressure on the intestinal wall, and functional, which is the paralytic obstruction, which is intestinal muscles cannot propel contents, and this may be temporary, often following surgical manipulation of the bowel. So, some clinical symptoms include pain, crampy, wave like colicky due to persistent peristalsis above and below the blockage, nausea and vomiting, dehydration, which results in dry mucous membranes, abdominal distension, hyperactive bowel sounds. Laboratory findings may include electrolyte imbalances or a loss of plasma volume. In imaging, which includes X-ray and CT scans, show abnormal gas and fluid accumulation in the intestines. Nursing management includes nasogastric tube care, which you guys are working on that skill right now, monitoring function, placement, and output, assessing patent comfort and tube patency, and that's done through X-ray, patient monitoring, done through electrolytes to detect imbalances, nutritional status. So you can do that through weight and how much of their diet they're eating, bowel sounds, and urine output and stool patterns. The pathophysiology of the large bowel obstruction is accumulation of intestinal contents, fluids, and gas proximal to the obstruction or causing distension. The progression is usually slower than with a small bowel obstruction and may be less dramatic if blood supply remains intact. Complications include if blood supply is compromised, intestinal strangulation and necrosis can occur, which is life threatening. Crohn's disease, also called regional enteritis, is characterized by a subacute and chronic inflammation of the GI tract wall that extends through all layers. Although its characteristic histopathology changes can occur anywhere in the GI tract, and most commonly occurs in the distal ileum and the ascending colon. Approximately 35% of patients have ileitis, and this is only includes the ileal involvement. 45% have ileocolitis, which is diseased ileum and colon, and 20% have granulomatous colitis, and that's only the colon involvement. Ulcerative colitis is a chronic ulcerative and inflammatory disease of the mucosal and submucosal layers of the colon and rectum that is characterized by unpredictable periods of remission and exacerbation with bouts of abdominal cramps and bloody or purulent diarrhea. The inflammatory changes typically begin in the rectum and progress proximally through the colon. Crohn's disease manifests as patchy involvement throughout all layers of the bowel, both small and large intestine. It may skip areas of the bowel and can occur anywhere in the gastrointestinal tract from mouth to anus. Ulcerative colitis begins in the rectum and proceeds in a continuous diffuse pattern toward the cecum, primarily in the large intestine. Crohn's disease can affect any part of the gastrointestinal tract, but most commonly involves the distal ileum and ascending colon, whereas ulcerative colitis is limited to the colon and rectum. In Crohn's disease, inflammation is patchy with skip lesions and involves all layers of the bowel wall, while ulcerative colitis causes continuous inflammation that starts at the rectum and extends proximally, affecting only the mucosal and submucosal layers. Symptoms of Crohn's disease include abdominal pain, diarrhea, often non bloody, and weight loss, and complications can include fistulas, strictures, and abscesses, and malabsorption. In contrast, ulcerative colitis typically presents with abdominal cramps, bloody or purulent diarrhea, and urgency with potential complications such as toxic megacolon, hemorrhage, and an increased risk of colon cancer. Surgical resection in Crohn's disease may not prevent recurrence, whereas in ulcerative colitis, removal of the colon can be curative. In terms of assessment, you want to obtain a health history to identify onset, duration, and characteristics of pain, diarrhea, urgency, tenesmus, nausea, anorexia, weight loss, bleeding, and family history. You want to review dietary patterns and the use of alcohol, caffeine, and nicotine, assess bowel elimination patterns and stool characteristics, and perform a thorough abdominal assessment. Achieving normal bowel elimination patterns and relieving abdominal pain and cramping are key. Preventing fluid deficits and maintaining optimal nutritional balance and weight. Minimizing fatigue and reducing anxiety while promoting effective coping. Preventing skin breakdown and increasing patient knowledge of the disease process and therapeutic regimen, and also preventing complications associated with IBD. Colorectal cancer is the third most common site of new cancer cases in the United States. Risk factors include age, family history, diet, and lifestyle, highlighting the importance of regular screening. Manifestations may include changes in bowel habits, blood in the stool, occult, tarry, or visibly bleeding, tenesmus, obstruction symptoms, abdominal or rectal pain, and a feeling of incomplete evacuation. Treatment is stage dependent and may include surgery, chemotherapy, radiation, or a combination of these therapies. So, for assessment, you want to obtain a detailed health history, including fatigue and weakness, assess for abdominal or rectal pain, evaluate nutritional status and dietary habits, review elimination patterns, and perform abdominal assessment, and examine stool characteristics for changes or presence of blood. You want to help them to achieve optimal nutrition and maintain fluid and electrolyte balance, reduce anxiety and enhance knowledge of the diagnosis and treatment, promote self care ability and optimal tissue healing, protect peristomal skin if applicable, and support expression of feelings and concerns and prevent complications related to disease and treatment. You want to prepare the patient preoperatively and provide emotional support, deliver postoperative care, including wound care and monitoring and managing complications, maintain optimal nutrition and support colostomy care, removal, application, and irrigation of the appliance, and promote a positive body image, discuss sexuality concerns or issues, and support home and community based care. Treatment of colorectal cancer primarily involves removal of the tumor and affected portions of the colon, along with the adjacent lymph nodes. The type and extent of surgery depends on the tumor size, location, and stage. Procedures may include colectomy, which is a partial or total removal of the colon, hemicolectomy, which is a removal of half or less of the colon, or an abdominal perineal resection, which is the removal of the affected colon and rectum with permanent ileostomy. Temporary colostomies are often performed and later reversed through anastomosis to restore normal bowel function, with a sphincter preservation possible in some rectal cancers. Patients may experience complications depending on treatment and timing of the diagnosis. Surgical risks include blood loss, infection, anastomostic leak, and incisional dehiscence. Chemotherapy can lead to fatigue, anemia, and increased infection risk, while radiation may cause radiation enteritis, resulting in diarrhea, blood in the stool, and weight loss. Advanced colorectal cancer also carries a risk of metastasis. So, an ileostomy is when the entire colon must be removed due to Crohn's disease or ulcerative colitis. Colostomy when a portion of the bowel must be removed, cancer, ischemic injury, or requires rest or healing in the cases of diverticulitis or trauma. The final consistency of the stool is dependent on the location of the ostomy. The closer the ostomy is to the small intestine, the more liquid the stool. Optimal self care of an ostomy is more successful when preoperative teaching is provided. For planned surgeries, a wound ostomy continence nurse will consult and is recommended to address patient fears and concerns. They provide educational materials and answer questions. The wound ostomy continence nurse also marks the abdomen for the best ostomy placement, considering border, contour in lying, sitting, and standing positions, and evaluates skin folds, bony prominences, scars, and creases to ensure proper appliance fit after surgery. This is a video that you can watch of the stoma care and nursing skills. So the prostatitis is an inflammation of the rectal lining. Anorectal abscess is a collection of pus near the anus or rectum. Anal fistula is abnormal tract connecting the anal canal to the skin. Anal fissure is a tear in the lining of the anus. Hemorrhoids are swollen veins in the rectum or anus. Pilodinal sinus or cyst is an infection or cyst near the tailbone, often containing hair or debris. Oh, I think I skipped another one. So, assessment of anal rectal disorders include obtaining a health history, including pruritus, pain, or burning, assessing bowel elimination patterns, diet, exercise and activity, and occupation, performing inspection of the anal rectal area. You want to help them maintain adequate elimination patterns, reduce anxiety and provide pain relief, promote urinary elimination, ensure proper management of the therapeutic regimen, prevent and monitor for complications. Encourage fluid intake of at least 2 liters per day and a high fiber foods. Administer bulk laxatives, stool softeners, and topical medications as indicated. Promote urinary elimination. Maintain hygiene and recommend a sitz bath. Monitor for complications. Educate the patient on self care and preventive measures. So now we're going to look at enteral nutrition. Last week we looked at enteral um, nutrition. So this week we're going to look at parenteral nutrition. So parenteral nutrition delivers nutrients intravenously to patients who cannot use their gastrointestinal tract. Central venous access devices are used for long-term um, PN administration. A total nutrient admixture typically includes lipid emulsions, proteins, carbohydrates, electrolytes, vitamins, trace minerals, and water. Inadequate intake to maintain an anabolic state. These are all indications. Impaired ability to ingest food orally or via tube. Patient unwillingness or lack of interest in consuming adequate nutrients. Medical conditions that prevent oral or tube feeding, and prolonged preoperative or postoperative nutritional requirements. You want to identify patients who may benefit from PN based on nutritional status, decreased oral intake of over a week, weight loss, muscle wasting, delayed tissue healing, persistent nausea and vomiting, hydration status and electrolyte imbalance, caloric intake, and blood glucose levels. Potential complications include a pneumothorax and air embolism, clotted or displaced catheter, sepsis, hyperglycemia and rebound hypoglycemia, fluid overload. That's why when a patient is on TPN, they are typically checking their blood sugars. Goals and purpose of TPN therapy are components, emergency contact numbers, demonstrating use of the equipment and how to handle and hang the IV, demonstrating dressing changes, demonstrating how to flush the catheter, and explaining potential complications and appropriate actions. Complications of abdominal trauma are directly related to the injury to the internal organs. Hemorrhagic shock may develop, particularly secondary to penetrating traumas. Peritonitis, potentially leading to septic shock, may develop with intestinal damage that allows fecal material to enter the peritoneal cavity. Ischemic bowel and paralytic ileus may also occur secondary to the traumatic event. With significant blood loss accompanied with sepsis, the patient may develop adult respiratory distress syndrome and disseminated intravascular coagulation, that DIC that we talked about last week. So you want to make sure you follow the protocol for advanced trauma life support. That is the ABCDE: airway, breathing, circulation, disability, and neurosurgical status, as well as exposure. And you want to monitor for tachycardia, tachypnea, hypoxia, and absence of certain signs. Okay. So Cullen's sign is ecchymosis, bruising around the umbilicus, and Gray Turner's or Turner's sign is ecchymosis or bruising in the flank area. These are signs that should be reported immediately as they indicate intra-abdominal or retroperitoneal hemorrhage. And I think that's it. We'll be talking in class. A lot of this will be on your third exam, so you will get a PowerPoint that highlights some of the key areas that will be on the exam.